Hi, yeah. So my name is Uri Landes. I'm a cardiologist at Rabin Medical Center in Israel. We know that inaccurate implantation of the transcatheter valve during TAVI can happen and may present as malposition or migration/embolization of the transcatheter valve. And when this situation occurs, there are several bailout strategies the operator can act upon. So in earlier or milder stages or cases, some valves have recapturable features and the operators may have a second chance to reimplant the valve, but many times it is simply too late or the valve does not have recapturable features. Then the most common thing operators do from time to time is urgently implanting a supplementary valve in a better position, either inside the first valve or in a different place if the first one was implanted at ectopic location. And currently, data on the sequela or consequences or even the risk factors for this urgent TAVI implantation is very scarce. So this was really a sub-study of the Redo TAVI global registry that we initiated and designed to collect data on patients undergoing Redo TAVI for transcatheter valve dysfunction for whatever reason. And currently, this registry includes 40 centers from Europe, North America, and Israel. But for this analysis, we collected data on consecutive patients that underwent dual valve TAVI from 16 out of these 40 participating centers, while defining dual valve TAVI as attempted implantation of a supplementary valve implantation during the single procedure, that is the index native aortic valve TAVI procedure. And the principal endpoints were straightforward defined as mortality at 30 days and 1 year. So we have a few. First, we noticed that the incidence of procedures that in which urgent implantation of the second valve was needed declined over time from 3% in 2014 to 0.9% in 2018. So this was reassuring and nice to see. And then we identified 6 factors that were independently associated with urgent second valve implantation. So these were a bicuspid aortic valve, if the patient had one, a significant aortic valve insufficiency at baseline, atrial fibrillation, alternative TAVI access utilization, also the use of early generation valve, and finally the use of self-expandable valve. And next, we found that 80% of these cases, the indication or the incentive to implant the second valve was residual aortic valve insufficiency after incorrect positioning of the first valve, which was 45% too high and 35% too low. The failure of the first valve presented as paravalvular leakage in most cases. Well, before making any conclusions, we should acknowledge that there are several limitations to the study. First, it is observational and didn't have any independent adjudication of event or collab analysis. Also, we used propensity score matching, which is well-accepted methodology, but cannot account for unmeasured bias that are probably also important, like anatomical root characteristics that we didn't have data on. And also, we didn't have data on alternative management strategies, which may be important or relevant, such as urgent surgery, maybe at least in some patients, and we didn't capture this data. Having said that, we can definitely conclude that there are clear temporal trends towards lower incidence and less need for urgent implantation of an extra valve during TAVI, which obviously outlines the advances in TAVI over the years, but also, and I'm being a bit more careful here, as some unmeasured bias may still interfere, but it seems that patients with a bicuspid aortic valve or aortic valve insufficiency at baseline may be at increased risk for this complication, as also are patients that in whom the TAVI is done using an alternative access or early generation, and maybe also self-expandable valve. And lastly, compare with TAVI with no need for supplementary valve, patient who did need one, did have a higher burden of complications that indeed translated to higher mortality at 30 days, not at 1 year and 2 years, but early mortality, yes. Well, I think we should be very careful when the TAVI valve jumps to the ascending aorta or to the left ventricle. This is not common, but when it does happen, we should reassess the options, as our TAVI population involve more and more low surgical risk patients. So surgery may be one extra option we should think about, given the high mortality in urgent TAVI and TAVI strategy. Now, I'm not saying it is better, and in most situations, it is probably not, but we need to keep that option in mind. But more importantly is prevention. Valve malposition should be abolished almost completely if we can, and the procedures obviously should be well planned and executed. And it seems like we're in a good direction.